RNMD is a show about hospital relationships from the perspective of doctors and nurses. You're very smart, and we know that you would never come to a podcast for medical advice. So obviously, call your non-podcasting doctor and nurse team if you need any medical care. Oh, and we should also mention that we don't represent any hospital at all. Ever. Okay, start the thing.
Hello, everybody. Welcome to RNMD, a show about doctors and nurses working together in this mad world of medicine. I'm Daniel, your doctor host, and today we have a special guest on our show. His name is Babak Behgam, and he is an emergency medicine physician who has an amazing Instagram page that we both love to follow, and he's a big supporter of our podcast, and is a big supporter of doctor and nurses relationships. So we're lucky to have him on today with us, and welcome him to our show.
First of all, thank you so much for coming on. I know that you just got a new job, and I really appreciate you taking the time to do this. So it's awesome to have you. And thanks for being such a strong RNMD podcast advocate. That's awesome.
Thank you, man.
Sure. Yeah.
Why don't you give us a little background about yourself first?
My name is Babak. My last name is Begum. My handle is Bob_back, because most people can't say my name usually, including my American cousins. So I used to be called Bobby my whole life, but then I trained with a guy named Bobby, so I've gone by my real name ever since then. But I'm a new attending. I'm an emergency medicine doctor, an ER doctor. I trained in Jersey, and now I work in Ohio, and I'm loving it. And I think my experiences with, or my passion for this RNMD relationship comes from my experiences with nurses in the past, especially during residency. And I feel especially looking through all of your posts and all your stories and all the comments that we get, there's a lot of misconception on both sides between physicians and nurses. And it's really interesting to see what everybody struggles with and some of the misconceptions. And I think it is really important to talk about it. So that's why I love this podcast idea and all of these topics.
Thank you so much. Yeah. I think it's funny when you really start to break it down, what people get upset about. First of all, most people, it's the same things over and over again. And there's people from Hawaii and Alaska and stuff, and they post the same problems that I have in New York. And I think that's so funny. And then also it's just interesting too, to see just the basic misunderstanding of each other's jobs.
Totally. Couldn't agree more.
I definitely am excited to hear from your perspective as an EM resident and attending, because me being from an internal medicine background is a different perspective. I'm kind of interested to see your interactions with nurses on the ER.
Yeah. So I will say before we get into it, so being an ER doctor and even as an ER resident, I think it's easier to interact with the nurses, especially when they have concerns, because in the ER, everybody works in the same space. My desk is a foot, 2 feet away from the nurse's station. And so if a nurse needs me to come see a patient because they're concerned about something, or if they need me to talk to a patient again because they're discharged, because they want clarification, or they request to speak to the doctor, it is very easy for a resident or an ER attending just to stand up and walk 10 feet into the room and kind of remedy the situation, versus as a medicine resident, especially at nights, you guys are on one wing of the hospital, and who knows where the nurse is calling from. And you might be doing other things like taking care of admissions or consults, putting in your orders. It is a little bit more challenging to just get up and physically go lay eyes on the patient. And that's why I think for ER doctors and ER residents, it's a little bit easier because of just the natural workspace. That makes things easier, and was a very different experience than when I was a resident and was taking calls on the floor from like ICU nurses, or like from a trauma nurse or something like that.
Yeah. I mean, that's similar to how it is for me too. Like now that I'm in the ICU, it's so much different because I have somebody right there in front of me and I can say like, hey, I have a problem. And they just like stand right up and come into the room with me, versus on the floor. It was like a nightmare. Like sometimes you don't know where the doctor is. You don't know if they're getting your pages. Maybe there's something wrong with the machine, or maybe you're being ignored, or maybe they're in turnover, or, it's just like, it creates so much extra stress that doesn't need to be there.
Totally. And I will say the months that I was I guess I'll use the example of trauma, because I think it's more indicative of like what generally the night residents or the skeleton crew on night goes through. Because when I was on ICU, we had 36 ICU beds, and there was a fellow and me, and not all 36 of those patients needed something at once. And I was just responsible for the ICU, not like, 80 patients on the floor. But just to give you an idea, I did 2 months of trauma, and during trauma, one rotation, I was on nights by myself. Like there were surgical residents, but they were there doing their own thing. And the other month I was with one other person, thank God. And on trauma, you are in a trauma bay, you go to all trauma codes, you go to all trauma alerts, you take care of all ER consults. So any person who falls, like an old person who falls and breaks their hip, yes, ortho is going to get called, but that person is coming to the trauma service. So you can just imagine how many consults come through the ER. And then on top of that, there's like anywhere from 80 to 100 patients on the trauma list that normally get taken care of by like 6 NPs during the day, who know those patients, who rounded on those patients, who get calls from the nurses. They're very knowledgeable about everybody there, and they handle whatever they need, whether it's a bowel regimen or to talk to a family or to order some imaging or follow up on something. And so when you're doing all of those other things and at night getting anywhere from 5 to 10 calls an hour, it can be really overwhelming. And you have to learn to prioritize based on the acuity of the patient. And I think that's where a lot of frustration comes from, because obviously, like, the patient has their own concerns, the nurse is concerned, you never want to ignore them. And that's why I think it's so important when you are the resident, to what I learned and what helped me was, if it was something simple, like they needed pain medicine, or if they needed a bowel regimen or something like that, I would just put it in. Or if the blood pressure is creeping up, I would put it in. But if it was something where you were truly really busy in an emergency downstairs, saying something as simple as, hey, I'm really busy right now taking care of a critically ill patient. I do not want to ignore you. I understand your concern. Can you please call me back in 10 or 15 minutes if that's okay? And they would be so happy. They'd say, sure. They would feel acknowledged. They would call me back. And if it was a true emergency on their end, they'd be like, hey, doc, no, not really. Like, this guy's pressure is 250 and he's complaining of crushing chest pain. And then you'd figure out how to deal with it.
Right. Yeah.
Versus an angry resident who's just like, I'm too busy, and blows the nurse off. That's just like not the attitude to have. And I think that some residents do that, unfortunately, or they're just overwhelmed and it comes off as being super like abrasive, and that's just not the way to go about it. So to everybody listening, I would encourage you to employ some kind of strategy like that, because it makes things run so much smoother.
Absolutely. Yeah, I think that's a great point. I mean, the times when I've had doctors do that to me and say like, hey, we're in the middle. An example is I had a patient that I needed something. It was non-emergent, but it was something that the patient was kind of like hyper-focused on and really, had a lot of anxiety and was asking me over and over and over again. So then what do? I have to ask the doctor over and over and over again to say like, oh, I just paged again. I just I'm just waiting, like that kind of thing, to like reassure the patient. And it was a resident and an intern that were covering, and we have like an internal text message system, and they just like sent me a text back like, hey, we're in an emergency, like as soon as we're done, I'll follow up. Cool. Because like my thing wasn't an emergency, and it was actually more of the patient, being kind of like having anxiety about this. So then I was able to tell the patient like, look, doctor's in an emergency right now. Like the patient can't really argue with that because they know their thing is not an emergency. So, hey, doctor's in an emergency downstairs. as soon as they come back up, look, we're going to handle this. And then that's the answer. Now I have an answer. But if I don't have an answer, if I have nothing to convey to the patient, then it's just this, what do I say? Every time I walk in the room, did you hear back? Did you, and it actually takes more of my time. Like, I don't want to deal with that either,
Totally. I've seen it in the ER where they're just like on the call bell and they want something and they feel like they're being ignored, and you're stuck in between this patient and the physician who really needs to either put in an order or go talk to the patient. And then you end up being the middleman and just kind of
wasting my own time.
I can't imagine how frustrating it is for floor nurses when that happens, honestly. I just think the residents, it's good to let them know, hey, I'm in an emergency. I will call back. And that usually helps a lot. Another thing I thought that was helpful that me and the residents that I was on trauma with was we kept like a list and we would write down like, hey, room number 827 called about this. This nurse called about this. So like when we were doing an admission or we were doing a consult, we had a list of like, okay, we need to, when we get a moment, call these rooms back to try and like, if we can, fix all of these things that were concerns at night. So not everybody does it like that. I don't know if they do it like that, Dan. Like, I don't know if you just prioritize in your head or go from like highest acuity, but like I think that's a good way of doing it.
I've seen a few programs that I visited do that. They kind of have like watchers and stuff like that, or like based on acuity, but we don't do it that way. It's more like we keep it in our head. Have you done rotations on the IM floor?
Yeah. When I was an intern, we did a month of night float, which is basically medicine. And that was good because we didn't do any consults, but we did admissions. So we went through the ER and did the admissions that we were assigned, and it all came in as a list. But then we would get calls on the floor too. So it was very much like, my senior was a medicine resident, was a PGY 2 or 3 medicine resident. And so we would be putting in medicine orders. And then if somebody had like an issue on the floor, we would go see them. So I think it was like being a medicine resident. And it was good because I got to meet all the hospitalists.
Was there a particular time during those night floats where you were kind of like frustrated or felt like there was like nursing interactions that really came to your mind?
Yes, totally. Because my perception of how to handle it as an intern was very different than as a third year with 3 years like under my belt. I think like if I was in the middle of doing like a complex admission, because I was just an intern, and I didn't know the medicine as well, and this person has like 20 things going on, and I'm getting calls about like a patient being nauseous, or like one of the pet peeves that I had was like getting calls on like the blood pressure is over 200, but the patient is sleeping or they have no symptoms. It would like frustrate me, and I would think like, well, why is this person calling me about like a blood pressure if the patient is sleeping? And when you learn about the nurse's roles, a lot of places the nurses are supposed to call when the blood pressure is over 200.
Yeah, we have a responsibility.
Right.
They're supposed to call if the heart rate is over 100. The nurse knows the patient isn't septic. The patient's just anxious or something else is going on. Heart rate's over 100. They're just conveying information to you as part of their job. And you can't get frustrated as a resident and, be short with the nurse. But I could see why some doctors, when they're overwhelmed, and this isn't a justification for their behavior, when they're overwhelmed or they're new or they're learning the medicine, or if they're not a medicine resident like I wasn't, I could see how they would maybe be short with the nurse or be like, why do you want me to put in a bowel regimen, or why do you want me to give a medicine to this patient whose blood pressure is probably over 200 all the time? I could see why that would happen. The other thing that I tried to do, because I did, and this happens in the ER all the time, we get patients from like urgent care or doctor's offices who come in with like asymptomatic hypertension. And I get calls from that from the floor when I was a resident. And I would explain to the nurse like, hey, I don't want to treat this asymptomatic hypertension. This person probably lives at this high of a blood pressure. And I think I could probably make them symptomatic if I acutely lower their blood pressure by just throwing medicine and trying to get the number down to make us all feel better. And when I explain my thought process, and you could apply that to any kind of call, that one, the nurse always appreciated it. It was like a discussion. It would put them at ease. And then, they would just say, hey, the physician is aware. They're aware of the blood pressure. We've elected not to treat it at this time, and they could write it in their notes. So it would cover them like based on their hospital protocol. And I feel like it would just, I don't know, kind of remedy the situation and make the nurse happy as well, you know? And I think that's the approach that everybody should take towards these kind of issues and nursing calls.
Totally agree with that. Totally agree with that. I think conveying what your thought process is the key, I feel. I do feel sometimes that I talk to Abby about this all the time. Some nurses don't want to know. Like, for example, I'll go to a nurse, I'll be like, by the way, you know, I want to change this antibiotic to this antibiotic because, you know, the blood culture was this or whatever. They're like, you can tell they don't care about why you're changing it. They just want to know, okay, what is it? And I'll do it, you know?
Yeah, totally. I mean, in my limited experience, yeah, but I mean, maybe Abby, you could weigh in on this, but I felt that, you know, most of the time, if you explain the thought process to the nurse, they were, you know, usually very appreciative, especially if they weren't like super busy or didn't have a million things they had to do too. And you're just kind of having a discussion about management. I don't know. I always felt like the nurses appreciated it.
Definitely. I think a nurse, just like a doctor, isn't one person with one opinion or one goal, right? So like we're different. So, I mean, you're definitely going to have different interactions with different people. And there are, of course, especially some of the older nurses who, you know, they have 2 years to retire and they've been doing this a long time. And maybe their spirit is a little broken with nursing, which is common in our field. Yeah, they're a little more task oriented sometimes. And I kind of don't blame them. I mean, if I was in this for 30 years, I mean, maybe I'd feel that way too. But I think there are definitely a lot of nurses that are curious and are interested in like what's going on. And a lot of nurses in general, the feedback that I get from the nurses is we don't feel included in the plan. People don't communicate properly. So if you do that, it's just, first of all, it's better for your team, right? Because now the person who's directly taking care of your patient knows what's going on, which is just good, right? And then also the person feels acknowledged that they're a healthcare professional, you know, and they're not just like a minion to like take orders and just do X, you know, A plus B equals C, which is really, and this isn't a doctor, you know, this is no one's fault, but the hospital system in general has made us all feel, I think, and doctors have told me this too, that we're just expected to kind of act like robots and just kind of do the plan and procedure the way that they've laid it out for us. So it can feel really nice when somebody acknowledges that, like, I have a brain and I have my own judgment and, you know, I could learn something and I could even use that to teach my own patients. You know, it's kind of nice.
There was a question that I got that I thought was a really good one that maybe we could talk about just for a sec. It was from a new nurse. He was like, you know, I think his experience was less than a year. I think he was on med-surg, and he said, what tips do you have for calling a physician, particularly at night? Because he worked at nights. And he said, you know, he said it flat out. He was like, I am concerned and sometimes scared to call the physician in the middle of the night because I feel like maybe I'm not conveying what I need to convey to them. And I am concerned about the backlash that I may get on the other end, depending on who the consultant is. And I can totally understand that. As an ER doc, we call everybody all the time in the middle of the night and daytime in the morning, everyone we call. And not all the consultants are nice, you know, not all of them are, you know, it's not all roses. I mean, you're essentially making work for other people. So I thought that was
every trope, right? Every single trope. You got to call the every baby troponin, right? The cardiology team.
Yeah. I mean, I have a saying, and we had a lecture about this. There's only 2 reasons to call a consult. One is you have a question, and 2, the consultant needs to do something for you. So I think if you keep that in mind, that's usually pretty good. But not to go off on that, I thought the question was really good by this nurse. From my experience, when I get calls from the nurses, when I'm like, okay, this person clearly knows what they're talking about, it's when the nurse is like super thorough and they don't have to use the mnemonic or whatever they tell you to use. It's like the nurse literally calls and is like, hey, I have this patient in room this, their blood pressure is this, but here's some collateral. Their blood pressure has been running 150 the whole time, and now it's 200. I still gave them the medicine they were supposed to get at night, and now they're symptomatic. They're complaining of like a crushing headache, or now they're altered. Like the nurse is on it. If I hear something like that, I immediately know this is actionable, you know. Versus, and it's a very different call. And I've gotten both kinds of calls where it's like, oh, the patient is, I don't know, the patient was complaining of stomach pain. What do you want to do about it? And I'm like, oh, okay, well, where's their pain? And they're like, well, they're sleeping now and they're not having any pain. You know, it's different. I mean, I'm using that as like a made up example, but like you can see the difference between those two calls of like how thorough the first call is, and how much collateral information there is versus just like, hey, here's a piece of information, you know? So I think that helps a lot. And some nurses might not know all the collateral. The patient might be completely new to them. And in that case, I think you have to just say, hey, I'm concerned about this patient. Any doctor who hears that from a nurse should know, like, hey, I either need to go dig through the chart myself or go see this patient because this is like something that's concerning to this person. I mean, I was told that as a resident. If you just tell the consultants, hey, I have concern about your patient, most reasonable people would understand that and try to help out. They should.
I started in nursing, you know, a little while ago, and I've been like a CNA. I've been in healthcare basically my whole career, like as long as I've been able to work. This is what I've been doing. And yeah, I was instructed by, when I was a brand new nurse, by like old school nurses, like, you're going to call the doctor and he's going to scream at you. Like he's going to, like, it was like an expectation. They're going to scream. And it's funny actually to phrase it even that way. He's going to scream at you. And that's how it was put to me, because it's a very old style, old world of medicine, you know, from these people who trained me's perspective. And it was like, just call them, hold the phone out. This is the advice that I got. Call them, say, this is so-and-so, I'm calling you about this patient. When you hear the person start to scream, take the phone away from your ear, wait until you don't hear it anymore, and put the phone back to your ear, and then just start going into your report and asking. And it's like such a crazy, psychotic way to conduct business, if you think about it, in healthcare for a patient. But that was the advice that I got. And I think what you're saying is definitely true. Like, you need to give as much information as possible that's essential to that situation. Like, you don't need to go all through your SBAR. You know, that's not necessarily, you know, important. You can say, like, a good example is, I've had multiple patients that their blood pressure is really, really high, and I have a duty to notify. That's something about nursing. We have a duty to notify the doctor. So if I see that there's a problem and I didn't take action on it, then I have liability. So they could come back at me and they might take my job for something like that if there was a poor patient outcome. So I have to notify you and I have to document that I did that. And that's my action that I did. So usually what I'll do, because I have to notify, is I'll say, hey, patient's blood pressure's this. He's on the phone with his girlfriend. They're having a fight right now. And the doctor will be like, okay, cool, let me know. And I'm like, all right, bye. And we hang up. And it's like, now I can document that I did my job and I'm not bothering you when it's not really important, you know?
Totally. And yeah, I've gotten calls like that too. Like, I mean, the nurses that are very good at it, like, I mean, they tell you everything you need to know. Hey, patient's heart rate is 105. They'll say, I mean, I've had good nurses be like, I don't think they're septic. They were admitted for chest pain. They don't have a fever. Their white count is 11. I think it's just reactive. Like, you know, are you okay with just watching like, they already have a plan. Yeah. You know, do you want me to give Tylenol and get cultures and a lactate, or do you think we could watch them? Like, when you get a call like that, you can tell, like, the person on the other end has really put the pieces together, went and examined the patient, looked through their chart. I mean, you know, done their due diligence. And if you get a call like that from a nurse, I don't see how you can just like not be grateful for. I mean, they've essentially done half of the work for you. You know, you're just kind of like, yeah, I've notified. You don't have to go digging through the chart, and it just makes all parties, you know, happy.
And pro tip for the nurses that are listening, do that if you really are sure, you know, you did your assessment, you looked through the chart. Do that so that it's going to make your job easier. If you just call an intern and say, hey, heart rate's this, right? And then now they're ordering blood cultures, they're ordering all this medication. Now you have all this work to do that maybe isn't even necessary. It's not even necessary for the patient. And maybe you already got labs on this person. Now you have to go back in, you have to do it again. You're creating work for yourself too. So like, check and see, like you have to use your own judgment, and then present that to the doctor.
Totally.
Okay, let's get into it, guys.
Let's do it.
Okay, I wrote down here. This is how this started. Okay, the conversation that you and I started talking about it was a surgery resident who wrote in and said that they did not appreciate getting paged overnight when they were covering if the patient could eat or not eat, and that the attending should see the patient in the morning and be the one to decide if the diet was going to be advanced or not.
Dan, you want to take that?
All right, guys.
Listen, there's a lot about this. There's a lot about this one. I see this all the time, man. All the time. The diet order's not in. What do we do? Is that what you're saying? Oh, yeah. From you, pretty much.
That's me. Yeah.
Actually, I'm kind of hungry right now. I can go for a diet order. It's annoying. And I think Babak made a really good point, because as an intern, you can see that as a very, forgive me for using this word, as an idiotic thing. It's in the middle of the night. Why are you asking me about a diet order? But if you actually think about it, it's the nurse being proactive. It's the nurse taking preemptive action to make sure that patient is getting what they need. It kind of makes sense, actually, because there's breakfast coming up early in the morning, and if that is not set up for the patient, they're not going to get their breakfast, and the whole orders and the systems are going to be messed up if you don't make sure it's done. So if you kind of understand how the hospital works and the way the patients get their care, then you'll be like, all right, yeah, of course I'll put the order in. It's not a big deal. But some other residents might be like, this is ridiculous. I'm not wasting my time for this. The nighttime shouldn't be for this kind of stuff. What do you think about that?
Yeah, I could see how the resident would think that too, especially on busier services, a 36-bed ICU where you have help versus like being the only resident on a trauma service. I could see how some residents could get frustrated. And, I think someone posted, they said, the nighttime is a skeleton crew. We're only supposed to put out fires. That's not exactly entirely right. Like, yes, the skeleton crew at night is number one job to put out the fires, but you can't ignore the, 5 to 10 calls you get every hour. Like there has to be, you have to have the ability to prioritize and to address the other concerns. And I think a good resident, an experienced resident, knows how to do that and develops the system how to do that. And if they don't know how to do it by day one, usually you learn by day 3 or 4. That's how like steep the learning curve was when I was on trauma. I was like, okay, we can't ignore all of these calls. Yes, we're crazy busy, but we have to do all of this. And I learned how to make it work. All of my co-residents who rotated through this trauma service learned how to make it work. And then at the end, we felt like we were better doctors because of it.
I loved this example because it's a small example of something I think we all feel, right? So it was really good. By and large, the doctors, what I heard from them was like what you just said. We're a skeleton crew. We don't have time. This is not our priority. We're dealing with emergencies. And then there's the flip side of the nurse who's dealing with a patient one-on-one. And I mean, so it can be kind of difficult for the nurse who is, first of all, a patient who's maybe NPO, like this example, the patient went for surgery, right? So the patient was NPO maybe 24 hours before and then went for surgery, and then now it's the day after and they're begging to eat. And sometimes they feel like we don't care if they eat or not. They really feel that. They feel like their needs aren't being heard. They're hungry. They get cranky. All they want is, a sandwich or something. They can smell the food next door, their roommate's eating, and they're like, what the fuck, why aren't you giving me food? And like, it can turn into more than just like a simple diet order. It can really turn into like the patient feels like it's like personal attack on their freedom because they're not allowed to eat,
So they feel like they're being deprived. Like it's like some kind of like sick joke. Like these people are withholding food from me, where it's literally a click of a button on the computer.
Right.
You know, I totally understand that and can't imagine the frustration from the patient and the nurse stuck in between, being, again, the middleman between this patient who wants to eat and the service that thinks they should be NPO. I will say, and again, ER resident, so you either can eat or you can't eat because you're waiting for a CT scan of the belly, or you have like 2 tropes that you need to rule out and are getting admitted. This eating problem is usually not too bad in the ER. Mm-hmm. Or if people are really hungry and they're pissed off at us, they just sign out against medical advice and go eat. So it's not like how it is on the floor. But I will say, I feel like, at least from my experience as a resident, and when I was like interacting with the floor and the surgeons, the surgical services, for the most part, are pretty good about who they want to eat, when they want to eat, and when a diet can be advanced. And I'm not a surgeon. I don't know the intricacies of how different surgeons advance their diets, from like solid food or starting out somebody NPO or clear liquid after this type of surgery. But where I trained and the people that I knew, I felt like they were very good about, the diet issues for that particular example. I don't know about what your experience is, Dan, but that was at least how I felt.
We deal with the same stuff on the floor, except it's like longer term. It's just like people, although it's not the patient's fault. Sometimes some of these services don't even care. They think NPO is nothing, like, yeah, NPO midnight, but you don't. And then the procedure is not the next day until like 6 p.m. So they basically NPO since the night before, and they're complaining, it sucks. And sometimes a procedure gets canceled, and they have to be NPO again the next night.
And they're so pissed. They're so pissed about it. And there's new evidence that shows that you don't even need to be NPO for midnight anyway. So like, what are we doing? Like, I don't understand.
They say that all the time. They say, like, for procedural sedation, because we sedate people in the ER, and they're like, oh, it needs to be like 6 hours. And I think the ASAP clinical guidelines are like, someone needs to be emergently sedated, right, or do a procedural sedation where you are giving things like ketamine or propofol or whatever. Like, just because they ate does not preclude them, or like doesn't stop you from sedating them for this emergency procedure that they need to have.
Right. Yeah. 6 hours is what it looked like the standard is to me. So I don't know what we're doing. And like Dan said, we cancel them all the time, and then they have to redo it. And they're like, I'm leaving and I'm going to Burger King on the way out. And I'm like, all right, go girl. Like,
I'm just like, thanks. Now I have one less on my 36 patient list. I think the issue on the floor becomes like, do you have time for sleeping? Because, in the ED, there's none of that. You're always on. Anything can happen at any second. You have to be on high alert. But on the floor, some of these residents have the impression that, it's overnight shift. I'm just kind of here for like putting out fires. Maybe I can get some time for sleep, Some places are like that. Our program doesn't have luxury to sleep. I feel like we're so busy over the night. We're doing so many admissions overnight, or we're taking care of so many issues overnight that we can never sleep. Residents going in with that mentality during the night shift already causes a problem, because they're setting themselves up to be so frustrated by anything that comes up,
Definitely.
Totally.
And that's one thing that I had to learn as a nurse too. That was like my misconception, because there were people who would do that. They would disappear and they would sleep. So when Dan, you kind of brought this to my attention. I didn't even realize that you guys are like downstairs doing consults in the ED. I didn't realize that you're doing admissions. Like, I had no idea. I thought if you're not there, you're sleeping. That's what I assumed. So there's a lot of resentment there from the nursing staff if that's what we think. We're like, oh, this guy's doing nothing. They're just in the back sleeping, like whatever. And then I talked to Dan, and he's like, no, I'm sweating and like literally running around the whole night, and I'm just like, oh, I didn't know that.
Totally. That's such a great point that you bring up, like that they don't know. I mean, I've experienced that. I've talked to nurses. They're like, wait, you guys are like doing admissions, or, you're like in the trauma bay, like doing this. It's their misconception, I think, is that we're either in a room, we're putting in orders and fielding calls from the floor nurses, and when that dies down, we're sleeping. And it's not. Most of the time, people are doing admissions and consults. So Dan, just to piggyback off of what you said, because I'm, again, ER, so we do 10, 12-hour shifts. But when we did trauma and you did overnight, or you took call, essentially, you were on for 24 or 28 hours. And that is brutal, being awake for that long. Most people do try to take a nap. I never did. And that's not like a pat on the back for me or anything like that. I, by nature, prefer working nights. Like, I'm not a nocturnist, but in the future, I hope to be a nocturnist. I work much better at nights. But as a resident, I was always like, not petrified, but concerned that I would fall asleep and be in some deep sleep, and then a trauma would come in, or I wouldn't wake up to the pager. So I never slept, ever. And that's not like a badge of pride. Like, it was just how I was. Like, I stayed awake because I was concerned that, I'm going to fall asleep and sleep through a trauma. And I know some people, because they do way more months of inpatient than me, they're comfortable, or they know when they can get like a 30-minute cat nap. But I think the attitude of like, okay, I'm going to do everything as quick as I can so I can fall asleep is not a good one, because you're there to work. And one of the intensivists that I worked with, he always was stressing to us, hey, you guys like should be going around and doing walking rounds on the ICU like we do during the day. You shouldn't be like lounging and sleeping. Like, part of being here at night is to be awake, to, yes, put out the fires, but to, go around and check up on these patients and see what they're doing. It's not a time to lounge and to sleep. And I think if you go into it with that attitude, you end up having much better interactions with the nurses who do need your help for, like, say something like a diet order or whatever that they need, because you're there with the mentality to work.
Yeah.
Definitely. Yeah. Absolutely. I mean, that's also just like that's a good tip for doctors too. Like, if you come around and I don't want to say rounding. Dan doesn't like this. We can let Dan address it in a second. But what I personally would love is if they had rounding on night shift. Like, I would love that, because then I could present to you my non-urgent things, and then I don't have to page you later. Because, I mean, like, contrary to popular belief, I don't like dropping what I'm doing and walking over to the phone, or do however your hospital works, to page the doctor. Like, it's a waste of my time too. I would much rather, if he's right there, he or she is right there, just say, hey, look, this is going on, whenever you get a chance. Like, that's how I like to handle stuff. But Dan was we talked about this for a minute, and he was very like, no rounding on night shift. So I don't know. Go ahead.
No rounding on night shift. I reiterate that. Are you serious, man? I'm not coming to, you know what I'm saying? You have 40 patients on your list. We're not going to every patient's room and like rounding on them. I'm not doing that, man. I'm sorry.
Come on.
Yeah, it's too hard when you have like 80 floor patients. There's no way. But at all the places that I was, some of them did do, so some of them rounded super like early before the actual rounds. It was kind of like a pre-round at 4:00. They would just like walk by and check up on all the rooms. Mm-hmm. The other way that I saw some like fellows do it when I was on trauma, or even at our institution, is they would like try to handle all the admissions and consults that came in. And then before they tried to go like lay down for 30 minutes or something, they would literally walk around the whole unit and ask the nurses like, hey, what do you need? Hey, what do you need? And let them know like, hey, I'm going to go like either, take care of an admission in the ER, or I'm going to go nap for 30 minutes, but obviously call me if it's an emergency. But they would do a walk by round on not 40 patients, Dan, but like however many that there were in the unit. And that let them take care of like the loose ends that the nurses had concern about, and put them at ease, because they knew if they did all of those things, it was much less likely that they were going to get a call from a nurse and could catch like 30 minutes of a nap. So I actually, think that's a really smart way to do it, even though not everybody does it that way. And it's not feasible to do it that way, depending on the number of patients that you have.
That's a great idea, honestly, because then instead of going to every room, every single patient, there's maybe 5 nurses on that floor. You can go to those nurses. And generally at night, we're kind of in the same area, so you could go and just even pop to the whole nurses station and say, like, does anybody need anything? And like you're saying, like, if that's a routine, then the nurses will save some of that stuff, because they know they're going to see you later.
Totally.
I think definitely what you're saying applies to like a unit, like ICU, CCU. You should do some kind of rounding of some kind when you start your shift. I think it's a totally different ballgame. But when you have like an internal medicine list where like 13% of them are osteomyelitis patients, and other ones are like stable, like COPD patients. You know what I mean? It's a little different. You don't have to really see them. Sometimes we just like run the list and then we sign out and that's it. And I don't think it changes patient care that much. But the more experience you get, the more you know what's important and what's not.
But I guess you can't be mad at the nurse then later if the nurse is paging you about what you deem unimportant things if you didn't come and check in with the nurse, right? So you can't have it both ways.
Well, I'm actually glad you brought this up because we were talking earlier about how much nurses want to inform us about things that are going on, and that's a big part of their job, There's another issue where they don't inform us when they really should inform us. And that comes up a lot because sometimes I'll be day shift and I'll come in day shift and I look through my patients' like vitals and their labs and I'm like, what's this? They had a blood sugar of 32? Nobody told us this. Or like they did have a blood pressure of 200, like you said earlier, but nobody told us. You know what I mean? So part of the night shift job is to kind of also gather information and relay that to day team that kind of conveys the status of the patient.
Overnight, we have admissions too. We have, some of these hospitals in New York City, the med-surg nurses, they have 7 to 8 patients on the regular. It's insane. Like you're flying around, like just like how you guys, it's like a skeleton crew and you have no support and no resources. It's the same for nursing. So like I can see how on both sides it would happen where like you miss stuff or you get frustrated or whatever. Like I get it. And then the real question becomes, why do we have these problems? Is it really, if I'm mad at the doctor, is it really the doctor's fault? Or why don't I have more support? Why do I have 8 patients,
I think a good way to remedy that also is to set parameters like, okay, patient has a potassium of 3.2, get an EKG. Oh, there's no EKG changes. Okay, the patient's heart rate is 110. I want to give a dose of metoprolol. And if it doesn't come down below 100, or if it goes higher than like 110 or the patient becomes symptomatic, please call me back. Like, I feel like giving parameters always helps. It kind of lets the nurse know when they should be calling you back or for what reasons or what the physician deems is like an emergency or a reason to know, rather than just being like, oh, hey, yeah, I don't really care about a heart rate of 105. Like, please don't call me unless it's an emergency. That's much more vague and also not pleasant versus when you're just like, outlining what you perceive to be an actionable like blood pressure or heart rate or whatever.
If you haven't heard about Anchor, it's the easiest way to make a podcast. Let me explain. First, it's free. There are creation tools that allow you to record and edit your podcast right from your phone or computer. Anchor will distribute your podcast for you so it can be heard on Spotify, Apple Podcasts, and many more platforms. You can make money from your podcast with no minimum listenership. It's everything you need to make a podcast in one place. Download the free Anchor app or go to anchor.fm to get started.
Okay, so this is just like a bunch of things that people wrote in about this topic. Okay, so the residents said nights is a time to, you kind of went over this. Nights is a time to tread water and put out fires. It is not a time to change bowel or diet orders. It's definitely not a time to update families. When we're busy, only emergencies are going to be a priority. Okay, take that. That's like half of it. Go ahead.
Yeah, it's kind of like before. I I agree and disagree with the resident. Like, yes, the nighttime is to put out the fires and to take care of the emergencies. But if you have downtime and they're calling you about diets or addressing a blood pressure or pain, that's another common one, or patients who can't sleep and they just need like a dose of Benadryl or melatonin or something. That is something so easy that takes like literally seconds to take care of. Will make the nurse happy, will make the patient happy. If you're really busy, it prevents you from getting another call. So I don't agree with the, hey, it's only for emergencies and emergencies only. And a word that I hear, all the time, or anybody, any resident will tell you, day team problem. That's kind of code for, hey, I'm too busy right now. See, Dan's laughing. I'm too busy right now. Like, I don't have time for what I perceive to be not an emergency right now. But it's again, it takes seconds to do those things, and it prevents you from being called again when you are in the middle of like doing an admission or putting out a fire. And so I think when you have time, you should address those things. The talking to families at night, I think, is its own nuanced thing. And I don't think it falls into this category because it depends on what the nature of the call is. Sometimes families want an update and they say they haven't talked to anyone in 8 days. And you look on the chart. I had this happen when I was on trauma. Someone was like, no one's called me. And I looked on the note and one of the NPs was like, called and spoke to so-and-so patient's like significant other and like gave a full update. That is a very different conversation to have than like an end of life discussion in the middle of the night where you are the skeleton crew guy coming into someone who's been in the hospital for 3 weeks who is either stable and okay, in that case, like I would prefer not to have a discussion with whoever family member if I don't need to. It's much more appropriate for the person during days who's taking care of them for 3 weeks to do it versus someone who's critically ill who may decompensate at any moment and whose family really needs to hear from the physician who is on call. And so I think that is not a simple yes and no, we call families at night type of answer. It's much more nuanced.
I mean, something that I do, and this isn't specific to family calls, this is something, and like a newer nurse might not know this. Like I had to kind of learn this from the nurses around me. It's not just family calls, even like imaging is a really good example. Like it'll be 9 p.m. and the patient's like, oh, I got a chest x-ray yesterday and I never heard the results of it or something like that. And it's like, okay, it's not my job. I'm not technically allowed to read imaging. And it's not appropriate for me to convey imaging results to that patient unless a doctor's already explained it to them, right? So right there already, if the patient wants those results, I have to call the doctor. But if it's, sometimes could be at 3:00 in the morning. The patient is just getting up to go to the bathroom and then just remembers all of a sudden. And now I'm going to page a doctor to come down to explain, and it's not even their primary team. So, I mean, what I try to do in those situations is say, the patient has a right to speak to a doctor, period. If they're in the hospital, if they want to speak to a doctor, I always give them that option because I'm their advocate and that's my role. But also, as their advocate, it might be better if the attending gives them those results, right? And I tell them that, I convey that, and I actually sort of encourage them to do that. Like I say, oh, there is a doctor here, but this doctor is covering for the doctor that you regularly see. That doctor that knows your case really well is going to be here in the morning. It might be better to ask that person. And 9 out of 10 times a reasonable patient is going to say, okay, I can wait until that doctor comes in.
Yeah, Abby, I totally agree with that. And I hope most residents do this, and I think they do. There are some things that you have to explain, like imaging studies. Like on one of these rotations, a family member wanted to know the results of, it was a very complex patient, and the imaging results was like not even something like you're talking about an x-ray. It was like an advanced imaging study of the brain, an MRI. And this person was in the hospital for 2 weeks or 3 weeks. I don't know. They were in the hospital for such a long time. And I think it's unreasonable to expect like a nurse to explain these MRI results to a patient. it's just asking too much of the nurse, in my opinion. And if that's the case, you as the doctor should, pull up the imaging, review it yourself, and call the patient or their family member or whoever it is, or speak with them directly. So I think the imaging, you bring up a really good point. And even like in the ER, there was a lot of times, because in the ER, we'll go and we'll talk to patients when we're discharging them, for instance, or when we're admitting them to the hospital. And then the nurses will take the paperwork, which usually has their like discharge diagnoses on there, for example, and then some like instructions on like, hey, these are things to do for nausea and vomiting. And a lot of times the patients will be like, well, no, I didn't understand this, or this wasn't conveyed to me. And they'll say, I want to talk to the doctor again. And it's very easy to be frustrated and be like, oh, I already went in there. I already went in there and talked to this person. Why do I need to go back again? And that's something that I learned in residency, and I changed that. Whenever I heard a patient be like, hey, I want to talk to the doctor about this, I just got up and went in there, because the patient's made up their mind. The poor nurse is just trying to do their job. And if you're like impeding that, it just literally takes 5 seconds to go back in there and address their, concern.
And they're not going to drop it either. They're going to keep.
They're not. And one of the nurses that I worked with before I graduated, he told me that he appreciated that I did that. Shout out to my guy, Ryan. He was like, hey, it's good that you did this. And he mentioned a couple of my co-residents who did that too. And I think it's important to do that. And it's, again, easier in the ER, but, I think in general, residents and physicians should do that.
Yeah. And not only is it like just a bad position to put the nurse in to read the imaging or to really discuss it in depth, it's inappropriate. Like, it's really out of my scope, There are definitely, like you're talking about, discharge planning and discharge education. That's within my scope. I can do that. But to really, like you're saying, some kind of like brain imaging, that's just not, I don't know the first thing about it. It's just not something I do.
I can read every MRI of any part of the body. I can read the CT.
Dan's a genius.
You can read venograms of the brain.
Of course. I can read ultrasounds of, you're probably a master at ultrasound, but sometimes I get a little bit lost in those images, man.
But you don't know pregnancy, though. That's the one thing you said, right?
We don't deal with pregnant patients that much.
Yeah, it's funny. Everybody's kind of in their silos. They don't deal with pregnancy, or they deal with, in the ER, you kind of see it all. You at least have some kind of I take care of a ton of pregnant patients, or potentially pregnant, and peds. We get peds, we get geriatrics. You see everybody in the ER.
Okay, hold on. There's only a few more for the MDs. I don't want to bore you.
Hold on. Good. I'm not doing shit. Good. Okay. Yeah, this is you, man. This is you.
Okay, it's all you, Dan. Ready? Okay. Overnight, well, we can address some of this. Overnight, we can have 40 plus patients, and we're supervising a junior resident. There's no time to do this. We're a skeleton crew. We're doing admissions and consults. We're getting paid about bowel regimens while we're in traumas. And here was the most interesting one. We're getting paid around $15 an hour, working 90 plus hours a week with no food and breaks. And the nurse gets a break. The nurse is making more money, working less hours.
Wow, that's a lot.
Ooh, that's a tough. Hold on. That question is so packed, and it's so layered, and it also touches. I don't know. Dan, I'll let you field this. I really would prefer not to comment on this. You know why? Because it touches on pay, which is a sensitive issue, and you can talk about it. We're residents. We don't get paid shit, I think the resident's question is kind of like, I don't know. It's like a resentful question. Like, the nurse is making this much money. I'm working some nurses I hear work 3 12s a week. Okay, they work hard job, but that's 36 hours. And some surgical residents I know break duty hours, which is like 90 hours a week that they can't report making. It comes out less than minimum wage. So is there some truth to what this resident's saying? Sure. But it's always sensitive when you bring up money, because you're getting trained. It's not like you're getting nothing for it. It's part of your training.
So whoever sent it, I think you're right. There's definitely some resentment in their tone. Are they right? It's not a matter of right or wrong. I think they make some valid points, but some of their points are just like guided by frustration or possibly some burnout, because, it is a training program, and nurses are working a strenuous job. You're not there to compare yourself to nurses, They have their own profession. They have their own, duty hours and careers and that are separate for you as a resident. You picked your career. You knew what kind of lifestyle you were going to have, the hours and the pay and things like that, and with the hopes of eventually maybe having the profession and salary that you like,
Can I give you my controversial opinion about this one? Because I think you guys should be tougher about this. I agree. I agree with what this resident said. I think that it's not fair. I don't care that it's a training program. You guys are doctors, right? If you were med students, it'd be a little different for me. But it is a job. It's not just like you're a intern getting coffee for people, right? People's lives literally hang in the balance. In my opinion, just from seeing so many of these residents cycle through in the years that I've been a nurse, I've seen it's very easy to take advantage if you're a hospital system. It's really easy to take advantage of residents because you're only there for a certain number of years. And like you're saying, you guys just power through, get in, get out, get done, right? So they're able to overwork you, underpay, the benefits aren't good, the working conditions aren't good. We're talking about why can't somebody put in a diet order for me? I mean, why don't you guys have more support at night? That's the real question, So we're able as nurses to unionize, and we're able to be kind of a collective group, and we can threaten the hospital system and say, listen, if you don't give us XYZ, we're not going to show up to work. And then what are you going to do? You guys don't have that because you have professional repercussions, and you're not there long enough to make a lasting change. So in my very personal opinion, they take advantage of you guys, and I think it's something that definitely needs to be rectified going forward.
No, I mean, you're right, but it's not as easy as you think it is. I mean, we're going to just do residency for a few years, and then, we're going to go ahead and do whatever we're doing afterwards, attending or other position of some sort. So it's not as easy to do something like that. You're not going to invest in a union because you're not going to be in the union in a few years. So people tend to invest in unions where they feel like, they're going to be in it for many years, if not a lifetime. So it's not as easy to do things like that. And even if you did create the union, how effective could it be, and how many problems are you going to cause in the process? So I think people weigh the positives and negatives of doing those kind of things, and a lot of them have realized that it's more negatives than positives to do it. But that's nonetheless to say we've made a lot of changes already throughout the years with work-life kind of things.
Yeah, Abby, I think there's a, truth to what you're saying. These residents do work a lot. Things have actually gotten, so much better compared to before. I mean, it's like an archaic system, but there's now duty hours. There's an emphasis on physician wellness. Everybody knows that the physician suicide rate is 3 times that of the general public. You read about it on the news. And so it is nice that there's an emphasis on wellness. At my program, we had retreats, at least twice a year, and bonding, and made an effort to go out. So that is helpful. And I also think, residents, almost all medical students who become residents have hundreds of thousands of dollars in debt. They've worked so hard to become residents. And you wouldn't want to, I guess, be outspoken against your hospital system for fear of retaliation and retribution. It's much easier to, like you're saying, just put your head down and power through, and just hey, everybody else did it. Why should I make noise? I'm not saying that's right or wrong. I just think that's the reality of the situation that most residents feel. They're already grateful to match because it's so competitive already to match, especially depending on what specialty you're in. And medical school was this such long, arduous process where you took all these tests and took step 1 and step 2. And now you're finally here. You're that much closer to being an attending, and you're going to, I don't know, I guess, ruffle some feathers and risk getting kicked out, because it has happened. Residents have gotten kicked out for a number of reasons. And most of the time, I think if you go back and talk to those residents, they would tell you they wish they didn't do it and just kind of plowed through, just to be Completely honest.
Okay, so the nurses who responded, by and large, they said we're all responsible for patient care, just like that they empathize that the resident was busy, but at the end of the day, like, they have a responsibility, everyone has a responsibility to the patient. Many patients don't sleep at night, so it can be easy to think that like things are going to be calmer or die down, but actually it's this idea again of 24-hour care versus is the day team going to handle it. So we're always taught in nursing that the hospital is a 24-hour business. So if the patient needs something, we're supposed to be there, and overall, that's the discrepancy that I'm seeing is like you guys are told the day team generally is managing this patient, but we're not told that at all. We're told that we have a job to do, and we actually are reprimanded sometimes if we don't take charge. If I went to a day shift nurse and I said, oh, XYZ happened, but that's a day team problem, the nurse would chew me out, and rightfully so, because it's really my responsibility to take over some of those things.
It sounds kind of like you sound like a mob boss when you say that. It's a 24-hour business over here. We don't sleep. We don't sleep or nothing. Come on.
We make money while we sleep, okay? Here are some people who wrote in and actually had some really helpful things. I thought this was kind of good. For this example of surgery with this patient, first of all, the doctor, before they even do surgery, should definitely be explaining, hey, you are not going to be able to eat until possibly the next morning after your surgery, and here's why. And maybe even provide them with like a written handout to kind of reinforce that idea. And then also if they contacted the nurse and told them that preemptively, because just like how Dan said, he doesn't know necessarily how some surgeons advance the diet. We definitely don't know some of that stuff unless you really work with a team regularly. So that kind of information would be really good, because then I could just say, no, doctor says no, not until the morning. It's not safe for you to eat. And then that ends that conversation, even if they ask me 100 times, There is a problem with this idea of if you're a nurse and your needs, either you're too scared to call, you're too scared to page, or you feel like you won't be heard. If you feel like you get blown off constantly, there's a problem that arises with that. And that makes some nurses go a little rogue. They might think, why am I even going to call this person? They're not going to do anything for me, or I'm too scared. And they use their own judgment, and then they start doing things outside of their scope that they shouldn't be doing. And that I have seen from other nurses. I'm going to be honest with you. So if there's effective communication just from the head of it, like, hey, this person is going to be XYZ, or like you said, parameters, that gives the nurse some guidance. But if the nurse is left to their own judgment and they don't feel comfortable calling the provider, or they can't get a hold of the provider because that person's sleeping or, is so tied up with a trauma downstairs, then, it can lead to bad outcomes. And I've seen that happen.
Yeah, I think if ever a nurse is concerned, they should call.
What about those little tips like the whiteboard and all that stuff? What do you guys think about that? You hate all that? Huddling? You guys don't huddle with us?
I think the whiteboard idea conceptually sounds good, but I think it has a few problems, and I'll tell you one of the main ones. I think the day team is so busy with so many things they have to deal with all day, including big tasks and small tasks, and a lot of the formalities that they have to deal with, rounding and things like that. And they want to get off the floor and go home as soon as they can. And the night team kind of has a little bit more downtime to deal with things. You know what I mean? And I think they're kind of doing a disservice to the day team to not kind of address some issues that come up overnight, and basically have the day team come and be like, oh shit, I got to deal with all this stuff in addition to what I already have to deal with. So I think the night team should, if they have time, take it into their own hands to deal with these things. And, if they couldn't get to it, then maybe put it on the whiteboard and have it trickle down to the day team. That could be something to consider. Maybe a hybrid of the two.
You know what's funny that you say that? It's actually like when we're talking about people contacting doctors in the middle of the night about like these like kind of smaller issues. That's me. Like that's me 100%. When I was on the floor, that is me. I am literally going.
Doctor, the patient wants a new pair of socks. They think their socks are their feet are warm. Their feet are too hot.
No, I literally used to print out the consult notes with a pen and go through every single recommendation and tick off if it had been ordered or not. And if it hadn't, I would message the doctors and say, hey, did you see that cardiology said this? Like, just so you know. And like, they hated me. Whatever. But it's what you're saying, Dan, is that I felt like it's not always, but sometimes I did have a little more time than the day team, especially a diet order is a really good example again, because like the incoming nurse, the day shift, they start off and they're flying, like they're just going like crazy. And if I can just make sure that like, oh, if that patient's going to get breakfast, like they already have a tray. If I can do those little things just to make their day easier, like why wouldn't I do that? Like I'm trying to set them up for success in a way, you know?
Wait, so Babak, I actually really think it's cool that you're really into this like doctor and nursing relationship thing. And I think a lot of doctors aren't that outspoken about these kind of issues. And I think that's why we started this podcast, to kind of raise awareness and open the forum for these kind of discussions. What kind of got you into this kind of, what got you into being interested in this RNMD issues?
So I think it was just like my personal experiences as a resident. Before I got into med school, I was a volunteer, and the people who showed me around the ER were the nurses. So I had a very good relationship with the nurses. And then in med school, I had some more challenging ones, particularly when I was on surgery and I wasn't aware of the surgical culture. And I thought that things would be better when I became a resident. And being a resident is totally different, because now you're in like the provider role or you're the physician, and the interactions are different than when you're a medical student. But for me, I trained at a 3-year program. My first year, everybody, when you're an intern, they kind of know the expectations. You're new. Most of the nurses were really good about being patient. And I felt like my intern experience, for the most part, was pretty smooth. But then when I was a second year, where I had more autonomy and I was just more busy, I struggled a little bit with just taking care of everything that I needed to take care of early on as a second year, as far as like my speed, the patient volume, the autonomy, and then like my interactions with some of the nurses. And 95% of the time it was fine, but there was some times where the nurse needed something from me, and because I was kind of busy or still kind of learning the medicine, I may have been a little bit short with them, or didn't know how to handle like, hey, I have somebody who's critically ill with X, Y, or Z. You're coming to me with a Zofran order. In my mind, you're like, hey, I need this Zofran order, and you're asking me 3 times. I probably could have handled it better as a resident. And the progression from second year of residency to third year of residency, where I got better at the medicine and I fixed my nursing interactions and the interactions that were, that the nurses had with me, it just made my life that much smoother as a resident. My patient care got better, and my relationship and rapport with the residents got better. And when I was a third year, it was just like, it was so smooth, because I knew the nurses trusted me, I trusted them, and we had a very good relationship. And I think there is that kind of like a learning curve when you're in residency, but not everybody kind of takes the same path. Some people it goes for them very smooth, and some people have a more challenging time. And so I think it's important to talk about it.
Yeah, definitely. I mean, you've been one of our biggest supporters, which I really appreciate. And that's why we saved this like juicy topic for you. Because you earned it.
No, I think that's why this topic is so good, because I want people to listen to this and kind of not just change the way they think, but also think more about how they approach like doctor-nursing relationships, and maybe think about how they can improve their behavior and how they do things on the floor or in the ED or wherever they work, you know. But yeah, thanks for coming on this podcast with us. We love to have you again. Guys, listening out there, follow Babak on Instagram. He's got a great page.
It's at Bob_back. It's BOB and then it's underscore and then it's back, like Bob and then you're back.
Dude, you got to come back on sometime for sure.
Yeah, no, we'll do it again. We'll do it again.
All right, thank you so much. We really appreciate it.
For sure. Thanks for having me on. It was a blast. Look forward to hearing.